Good afternoon, everyone. My name is Cirillo, and I am the CMHSI coordinator from Metro Public Health Department. And I'm delighted that you've joined us today for the Policing Policy Commission Brown Bag Luncheon on the Nashville model, 24/7 crisis treatment center and pre-arrest diversion. I'm going to introduce our panelists and our topic of discussion today. Launched in 2016 by Metro Public Health Department, the Community Mental Health Systems Improvement brought together MNPD, other Metro departments, and the private sector to redesign the mental health system to address the unmet needs of individuals with serious and persistent mental illness so that preventable and avoidable incarcerations decline in Davidson County. I am pleased to introduce our speakers today. Our first speaker is Angie Thompson. She is the Director of Behavioral Health and Wellness Division of the Metro Public Health Department of Nashville, Davidson County since 2008, where she leads efforts for public health to define and fulfill its role in promoting emotional well-being through public health and population health approach. She is a founding member of the All Children Excel Nashville and a member of the ACE Nashville leadership team and the Suicide Prevention in African American Faith Communities Coalition, and works as part of the multi-sector community effort led by the Division on Overdose and Opioid Reduction and Prevention Program. She has led the work of Metro Public Health Department in the decriminalization of mental illness and the Community Mental Health Systems Improvement Initiative since 2016. And in 2018, she was appointed by the mayor to serve as the co-chair of the Behavioral Health and Wellness Advisory Council, which represents Metro Nashville. She serves as the vice chair of the Tennessee Department of Mental Health and Substance Abuse Services Policy and Planning Council for Region 4. Ms. Thompson has led the work in the division to receive several local awards and national recognition. Right after Ms. Thompson, Deputy Chief Damian Huggins will be up. And I want you to know a little bit about Damian's background. He has served on the MNPD for 28 years. He was promoted to deputy chief in 2010. He has been the deputy chief over 3 of the 5 bureaus at MNPD. During this time, he created the MNPD Chronic Consumer Program to share data and coordinate across sectors to address the needs of this population. His work has included patrol officer, community bike officer, sergeant vice narcotics, officer and supervisor on SWAT, and he progressed through the ranks as a lieutenant captain and commander of the downtown commander of the downtown Central Precinct. During his tenure as Central Precinct commander, the Central Precinct was Precinct of the Year for efficiency and crime reduction for several years. Deputy Chief Huggins has a doctorate in business administration and a master's degree in public service management. He has also attended the FBI National Academy, the Police Executive Leadership Institute, and the Police Executive Research Forum Senior Management Institute for Police. Our final panelist is Amanda Bracht, and she currently serves as Senior Vice President of Clinical Services at the Mental Health Cooperative, which is a non-for-profit mental health center based in Nashville. In this position, Ms. Bracht oversees all clinical services that include the 24/7 mobile crisis team, the crisis treatment center, the crisis stabilization unit, outpatient clinic services, therapy services, criminal justice liaison services, and a multidisciplinary team that provides psychiatric services to inmates who are incarcerated in Davidson County Sheriff's Office facilities. Ms. Bracht's most recent work has been focused on expanding access to comprehensive emergency psychiatric services, implementation of a medication-assisted treatment program, and the development of a true integrated model of care focused on improving overall health outcomes for consumers at the Mental Health Cooperative. Ms. Bracht is a native of Tennessee who earned her bachelor's degree from Tennessee Tech University and her master's degree in clinical social work from the University of Tennessee. She has been a licensed clinical social worker in Tennessee since 2001. A brief moment on housekeeping. We will hear first from Ms. Thompson, and then Deputy Chief Damian, and then Ms. Bracht. Afterwards, we will open the floor to questions. We would just ask everybody to raise their electronic hands when they have questions during the question and answer session. Many of you have access to your mics right now. As you know, WebEx is a live environment, and we would just ask if you could keep your mics muted as our presenters begin. With that, I'm going to turn this over to Angie Thompson.
Thank you, Dia, and good afternoon to the members of the Commission. The mission of the Metro Public Health Department is to protect, improve, and sustain the health and well-being of all people in metropolitan Nashville. The Metro Charter charges the Health Department with responsibility for the physical and mental health of the people. So we know there's an inextricable link between physical health and mental health across the lifespan, and this sets the context for the work of the Division of Behavioral Health and Wellness. Next slide, please. The core functions of the division are to build the capacity of the community to address behavioral health issues and promote behavioral health and wellness, develop partnerships to prevent and mitigate addiction and mental illness and improve access to services, participate in advocacy and policy development, and utilize a population health lens to formulate system solutions. And central to these core functions is serving as a neutral convener to address complex multi-sector issues and utilizing data to guide and inform the work. Next slide, please. So today I want to provide a snapshot of 3 behavioral health and wellness initiatives and how they intersect. The Community Mental Health Systems Improvement mission is to redesign the mental health system to address the unmet needs of individuals with serious and persistent mental illness so that preventable and avoidable incarcerations decline in Davidson County. Mobilizing more efficient and effective use of mental health and criminal justice system resources has begun to improve the alignment of services with needs, promoting jail diversion, and emphasizing resiliency and recovery. With respect to adverse childhood experiences, science makes it clear that adverse childhood experiences negatively impact the architecture of the developing brain and that children thrive in safe, stable, nurturing environments of supportive families, caregivers, neighborhoods, and communities. In response to Nashville's 2015 Community Health Improvement Plan, Behavioral Health and Wellness, along with the Family Center and Prevent Child Abuse Tennessee, convened a diverse group of community stakeholders to address supporting the mental and emotional health of families and children by preventing and mitigating the impact of adverse childhood experiences. This led to the creation of ACE Nashville, a collective impact initiative which has engaged hundreds of stakeholders across Nashville. The Opioid Overdose Response and Reduction Program engages cross-sector resources to reduce both fatal and non-fatal overdose. The substance use disorder that overdose activity stems from has a well-established overlap with both mental illness and ACEs, as both are known predictors of and contributors to the cycle of addiction. All 3 of these initiatives address complex issues requiring multi-sector, public-private collaboration to effectively impact systems change, emphasize treatment over punishment and/or entanglement in the criminal justice system, engage stakeholders in behavioral health, justice, and advocacy arenas, address behavioral health needs across the lifespan, are grounded in trauma-informed principles, policies, and practices, and seek better alignment of resources for more responsive and efficient systems. Next slide, please. This cutting-edge, system-focused work has led to the recognition of community partners in behavioral health and wellness as innovative and award-winning leaders. Examples of this are listed on the slide, but I'd like to highlight that in 2019, the Community Mental Health Systems Improvement work was one of 5 finalists for the National Navigator Award, which recognizes the ability to implement a great idea that improves public sector services and the communities they serve. Next slide. So the Community Mental Health Systems Improvement benefits all Metro Nashvillians. This is done by linking and leveraging work and resources across and within public to private sectors. So some of the efforts around this CMHSI emanate from the Public Investment Plan, which was created in 2016. And that created decriminalization as an important focus of public systems development. Defined problems as well as solutions. It's data-driven, evidence-driven, solutions-focused. Secured $3 million to build the Crisis Treatment Center in 2018. Created a first-time investment in Metro funding to support the services of the Crisis Treatment Center. Launched the Behavioral Health and Wellness Council in 2018. Maintains engagement of 20-plus stakeholders in this. So CMHSI was convened to address a problem that impacts multiple systems, and that is to improve access to psychiatric care for all citizens of Nashville. The lack of access to care results in over-incarceration of the mentally ill, overcrowded ERs, overburdened police and courts, unnecessary suspensions from school, and fragmentation of resources. So given this context, I now want to turn it over to Deputy Chief Damian Huggins to provide more specifics.
Thank y'all, and thank you for letting us, or the police department, be a part of this discussion. I'm going to go kind of pass through the slides. So I think we have a presentation. It was some slides I put together quite some time back, but to discuss where we're at now, we have to talk a little bit about what got us here. So back in 2008, I was the commander of Central Precinct and recognized a lot of issues in the downtown precinct related to mental health, vulnerable populations. At that time, we started looking at what are our options and resources, and I'm glad to see an old friend, Tom Turner, on here. One of those resources immediately engaged was the private sector to try and see what they could do to help. They employed an outreach worker that reached out to a lot of the vulnerable populations that we were identifying at Central Precinct, but we also wanted to see what we could do to try and where are we missing the services that government can provide in the private sector to this vulnerable population, because I certainly felt like police didn't have the resources that best address these problems or even could identify those problems. And that collaboration with mental health partners, psychiatric help, physical health, addiction help, the health department, all those would be an advantageous partnership to have, except that was kind of a novel idea in 2008 as far as the government was concerned, because everybody's busy going about their day. So you would go on with the slides and you can just kind of keep up with me as I go. When you look at the very next thing, it starts talking about we were seeing arrest and release and arrest. So it got with the sheriff's department and Sheriff Hall and Chief Ford and Jeff Bloom, who used to be over their behavioral health section in the sheriff's department. And they created a risk assessment tool to catch our most vulnerable when they show up time and time and time again. And we thought that was a really good work in the right direction, and that we would start identifying problems and meet some of our obligations to that vulnerable community. And next slide, please. And as we started looking, I realized that in Davidson County, most everybody that's arrested, I would say 99+ % are released within 8.5 hours for minor violations of public intox, trespass, things that may be most often occurring in mental health issues and things of that nature. And while I don't think that incarceration is the best or necessarily the right route to address mental health concerns, when there is no other resource and you continually go down the same road of arrest, rearrest, all the trauma-informed training that I've had says that's certainly not a best practice either. So starting to look at that, we realized that we had to identify those people that were having some type of crisis. And I created in the police department, the chronic consumer, the highest utilizers, to be able to share that information with our mobile crisis folks, with the downtown partnership, with people that had resources that could reach out to this community to try and address them, so that police didn't have to. It was diversion without there being a formalized plan. It was our attempts as a police department to collaborate data and to start showing that we could do something different. The epidemiology of criminology says penicillin is not the right medicine. It's not getting you better. You change the medicine, and government certainly ought to be able to do that in regards to what's working and what's not. So if you can go to the next slide. And part of the process of getting there was to do a cost benefit analysis or opportunity cost evaluation of looking at what those costs were for high utilizers, to get past some of the hurdles of, hey, well, if you arrest people, you take them in to incarcerate them, there's going to be increased costs, there's more trauma. And so I started gathering the data on that and looking at arrest costs per arrest and ambulance rides that were all involved in an aggregate way with this group, including DCSO overnight jail stays. Next slide. And what we found is that if you look at the comparison of the groups between 2011, 2012, and then the next slide, please, 2013, and some of this information is old for a purpose, because to show you that this is something we've been collaborating on and working on since 2008 and tracking groups of high utilizers since 2010. If you look down at the before and after costs, including overnight jail stays, the overriding majority of the costs and the jail stays go down, not up. So addressing a problem and providing resources can be a cost-effective manner to do things. And I think it's more important than the costing part is that you're addressing people that are in their most vulnerable state and not just looking the other way because that's the way the system works. So with this data and this evidence-based approach, we were able to really put some things into place and be part of discussions about, okay, where can we look for justice reinvestment initiatives? Where can we put in programs that takes this data to the next level and starts identifying the individual problems and assessments that are needed for these vulnerable populations and individuals that we encounter time and time again. Next slide, please. The remainder of these slides go through some comparisons that talk about the arrest rates from when the individuals were initially identified as the highest utilizers. In 12 months, there was 1,378 arrests with that group. And you can see how it dropped off from year to year to year with that same group. Next slide. The same with the 2011 chronic consumer group. You can see where it initially starts off and then drops down, and you can track the groups either amongst each other or within those individual groups. And if you go down to the next slide, you'll start looking at, when you start looking at the reduction of arrest time spent, how many days of police officer time it put back on the streets and into the communities. So that was that's a quick look at how we were going about trying to do a cost benefit analysis. And if you would go to the last slide, about the last slide, I guess. It has next steps. It talks about working at coordinating information about the chronic consumers or high utilizers between all government programs, working towards shared databases to better identify the overlap of client services to better drive resource allocation and need. Go to the problem, not around it. Track these results and assess what's working and what's not. I think the slide with the light bulb. And use shared data to define where focus efforts and where individual risk assessments and problem solving partnerships are needed. And number 5, the last one on that next steps page, next slide, please, talks about defining an executor for the process. So that was really a catalyst for being what I thought was such an opportunity with the CMHSI group and the collaborative, was to take program data across all of government, share it in an aggregate way that can't be shared with police, and let's look at problems and solutions and find and identify resources, but somebody has to drive that. If not, when people change, leadership changes, those projects fall off the table. And if you will jump to the next slide, some of the things that we identified early on that were at need, working with people like Robin Nobling, Bob Vero, Amanda Bracht at the Mobile Crisis, and others, was that we know that early on that we're going to have information exchange with our officers so that we could have chances for diversion. So anytime we did a transport to somebody's or for somebody to mental health facility, we created a flag that informed the officers that this person had a prior transport to better inform the officer and maybe provide better outcomes going forward. Also, we got with the mental health courts. Judge Blackburn's worked with us often. And we got a flagging system in place for warrants that came out of the mental health court because they look like any other criminal warrant. But it's important for officers to know that those are coming out of mental health court when we engage with those individuals for better outcomes. We also knew that we wanted to have the ability to provide alert notices on the master names for the chronic consumers, which are the high utilizers that we have, because many of times we feel like those are those issues will be cross-sectional. across the department. So we also have language in our alert systems that provide for a preferred response to mobile crisis if there's any indication of a mental health issue that may be a part of that incident. And when we were looking at the problem as a whole, is why do we have 2,000 people in jail in Davidson County with mental health issues? We looked at the 2,000 calls that police had and found that 98.5% were diverted from jail when the police department knew and had information about a mental health issue being there, and that we trained our officers at least 100 hours beyond CIT training, which is the Memphis model, and we trained to all officers, not just teams of officers. So we were very good at diversion when we knew there was a potential issue, but the system has flags that are hidden from police that we're not aware of. And until we have an aggregate collaborative database and work together on these things, there's not going to be opportunities, or we're going to miss opportunities for diversion. So that's the quick version, and I'll hand it off to Amanda so we can be ready for questions down at the end of this. Thank you.
Thank you, Damian. So good afternoon, everybody. And again, thank you for giving us the opportunity to speak about the work we've been doing over the last several years. While the slides are being pulled up, my focus is that in my presentation will be one of those great outcomes that came from the Community Mental Health Systems Improvement Committee that Angie talked about. In the early days, we brought in stakeholders, public organizations, and criminal justice organizations to look at what's going on in our system, because we were seeing a rising number of people who were mentally ill in our jails, and their length of stay in the jail was also going up. So we knew we had an issue. At the same time, being a community outpatient provider, I knew some problems on our system's end, in that we had people who needed immediate psychiatric treatment, but we were having difficulty accessing that treatment for them in a very quick way and a safe way. And we were at the same time having long delays in getting people who needed inpatient care into psychiatric hospitals. That wait time back in 2017 to get an individual who needed inpatient care in one of our state hospitals was averaging about 27 hours. And during that 27 hours, individuals were often waiting in hospital emergency rooms, often waiting in our previous walk-in center, which is a traditional office building, with police as their escort, so to speak, for that entire length of time. And all the stakeholders came together. We were all seeing the same problem, in that we needed to improve access to mental health crisis services in our city. So that led to the development of the Crisis Treatment Center. This first slide just shows you the outside of the facility that we opened in February of 2019. Next slide, please. So as I mentioned, CMHSI came together, and please click again. I think it's missing some bullets. There we go. We looked at the problem. So a person in a mental health crisis, if they need to access care, there was three main ways they could access care. They could go to a crisis walk-in center, which again, we've been operating for a while, but it was in a less than ideal facility layout. Or they could go to an emergency room. Or if 911 was called first and the police were the first responders, unfortunately, sometimes they would end up in jail, as to Damian's point, that they wouldn't necessarily know the officer responding that this person was having a mental health issue. It may have looked like a criminal matter, and they ended up in jail. So if you click on that slide again, same slide. So you have the police as one entryway point. Click again, and you have, one option they have is folks going to jail. You have EMS as another entry point, people going to the emergency room, and then another click. Then you have, they could get to a crisis counselor and go to a crisis walk-in center. Then last click on this slide, what we wanted to do is to make sure that we could route as many people who were presenting in crisis to actual mental health care, and try to bypass unnecessary use of emergency room. Please click. As well as the police, giving them another option if the person had not committed a serious criminal offense, and the officer had the tools to know that that person had a mental health issue. They needed to be able to get them immediate care so that the officer could get back on the street. So click to the next slide, please. So as a mental health provider and as the crisis provider in Nashville, how are we going to do this? We had to be able and willing to take increased acuity. one of the issues we had before, if somebody was highly agitated, often officers were having to stay with us, or we were having to direct them to an emergency room for the safety of the individual. Because we did not have a facility that was well equipped, or the staffing patterns in order to be able to maintain the safety for that individual as well as our staff. We also had to be willing to take on increased medical acuity, because often individuals who are having a psychiatric issue also have co-occurring substance abuse issues. And while ERs are great, it's not necessarily the best place for somebody who's in a mental health crisis who's not having an acute medical issue, because they get triaged down, and emergency rooms are great, but they are not designed to provide rapid and intensive psychiatric treatment. Next slide. So the only way we were going to be able to do these things and to accomplish our goal of increasing access to care is through a partnership. And thankfully, we had great partners already in place with the health department, Metro Nashville PD, the state of Tennessee, and then the mental health cooperative as the community provider. And things kind of aligned for us in a way that it was just meant to be. And what I mean by that is that we were able to apply for funding from the Metro government for a public investment plan. We presented data that said, look, we've got an issue with officers' time being spent on mental health calls. We have an issue with people having extended wait times in emergency rooms. We can do it better if we reinvest this money in a different way. So the city of Nashville agreed to funding for the mental health co-op to hire additional staff, both medical and mental health technicians, so that we could provide that safe place for people who were in a psychiatric crisis and release officers back to the street. At the same time, we got that city funding. The state of Tennessee, the Department of Mental Health, released a grant for one-time funding for communities who were looking to do pre-arrest diversion projects. The caveat for getting that money, however, was that you had to have a local match. Well, we had just gotten a local match from the city of Nashville, so we're able to use the public investment plan as our match. The state of Tennessee also put up, we were awarded that funding, and then the mental health co-op, as a non-for-profit agency, we put some of our funding to that initiative as well. Next slide. You'll see here, this is just the breakdown of the funding we received at that time. So $400,000 from the city of Nashville, 2.6 one-time funding from the state, and then $900,000 for the mental health cooperative. We used the bulk of the money from the state as well as the mental health cooperative to build our crisis treatment center. Next slide. And this is the crisis treatment center, opened in February of 2019. So what we are able to do here is we have a secure facility that has lots of safety features for individuals who are in a psychiatric crisis. We have suicide-proof rooms. We have non-ligature points in the restrooms. But more importantly, we're able to put all of the clinical staff together in that central area. That center picture there is the large staff area where we have nurses, we have psychiatric providers, whether that be a psychiatrist or nurse practitioner. We have crisis counselors, our crisis triage, our peer specialists who work directly with individuals in crisis. They all work out of that central area so that we can, A, have good lines of sight on people who are having an issue and respond very quickly to them. If someone is threatening immediate risk of harming themselves, we're able to, again, respond immediately and see them. And if individuals do need inpatient care, we have a high acuity side, which is the slide that will be on your right with those 4 chairs, where they can be under direct observation and staff can engage them until we can get them into a hospital bed. The picture on your left is the 23-hour treatment unit. Often individuals in crisis need a safe place to get some rest, get a nursing assessment, and then start their psychiatric treatment. We can initiate medication. They can meet with counselors, and then we meet with the discharge. They will meet with the discharge planner to work on what their long-range plan is going to be once we release them from the unit. Next slide. So as part of the facility, we have a secure area for police. So police have a separate entrance than our walk-in. So people can walk in the front door and get assessment. If police are the first responders and they have someone who's having a psychiatric issue, they can bring them directly to us 24 hours a day. And there's a side entrance that's dedicated just for the police to bring individuals in. Once the police bring them in, they are able to immediately hand off to our treatment staff. And what this slide indicates is prior to opening the CTC in fiscal year 18, we started tracking how long officers were having to wait in our previous walk-in center location. And the average wait time anytime an officer brought someone in was 98 minutes. By fiscal year 19, we opened CTC the first of that year. We got that wait time down to 14 minutes. That is so important because that person in crisis, officers are great, but officers need to get back on the street. That individual in crisis needs to be treated by mental health professionals. And so by having that quick handoff, we can get officers back to doing what they do best and can get our treatment staff doing what they specialize in, which is engaging people in crisis, treating them, and stabilizing the situation. And then as you can see in fiscal year 20, we've gotten that handoff, that wait time down to 8 minutes for officers. Next slide, please. This illustrates the police-initiated calls to mobile crisis. And these are face-to-face assessments that the Metro Police Department was the first responders. They get to the scene, they determine that they need mental health assistance. They can either bring them to the crisis treatment center or we will go out to the scene. Majority of time, they will bring them to the crisis treatment center for all those reasons that I spoke about earlier. So as you can see, when we opened CTC in fiscal year 19, we had 959. By fiscal year 20, that had gone up to 1,018. And we're still seeing that increase each month. Next slide, please. One thing I don't think we fully anticipated when we opened the crisis treatment center, we were so focused on being able to increase the accessibility when law enforcement was the first responders. We didn't really realize the impact it would have on our walk-ins. So people who have no contact with the police, they just hear about our service or they call and say, I need help, and we have them brought into our crisis treatment center. We've always had walk-ins, but as you can see from fiscal year 19 to 20, we had a pretty significant jump in the walk-in traffic in our facility, which is great. I mean, we prefer that. If people need the service, we want them to know how to access it and get that care. But we, from fiscal year 17 to 20, you can see a pretty significant increase in that traffic. Next slide, please. And then this shows the crisis treatment admissions. So there's two main ways people can get admitted into the 23-hour treatment part of our facility. One is that they walk in or the police bring them in. The other way is if individuals present in emergency rooms or other locations throughout Davidson County, whether that be a homeless shelter, it could be a boarding home, and we assess them and we think that they don't need inpatient treatment, but they need to, go back to the previous slide, please, but they may need some sort of intervention. They're not safe to remain in the community. We can bring them to the crisis treatment center for services. And as you can see, since fiscal year 17 up to fiscal year 20, we've had a dramatic increase in those people who we've been able to provide treatment for. Next slide. So all of that's great, but what do folks who receive the treatment, what do they say about the service? So we do what we call consumer satisfaction surveys as people are discharging, and this illustrates just our average in 2020, 94%. This is something we look at each month. Individuals also get an opportunity to write comments about things that they would like to see changed, and all too often it's things like, I wish I could have stayed longer, or I wish there were more outdoor breaks, those types of things. There's rarely, if ever, any major issues regarding their treatment stay, other than they would like to stay a little bit longer. Next slide, please. So, obviously we have to look at this from a cost savings standpoint and a business standpoint. So if we look at the number of people who MMPD has brought to our treatment center versus arrest, and many of these folks, based on their behavior, could have been arrested for disorderly conduct or some minor offense, but instead the officer recognized them, they brought them to us. But had that not happened, had those individuals been arrested, we estimate a cost of about $2.37 million just to the jail system alone. Now, this is based on 2017 data that at that time, if we incarcerated somebody who we knew had a mental illness during their incarceration, they spent on average about 12 days. And the average daily cost for incarceration at that point per DCSO was about $100. So that's how we came up with that calculation. That does not account for court time. It doesn't account for the officer's time. That's strictly just if they were incarcerated in the facility. So then we also wanted to look at the cost savings to Metro Nashville PD. So if you remember at the beginning, I showed the slide about wait times. So the total wait time was in fiscal year 18 was over 1,000 hours. If we look at that over the cost of that year, that would have been $54,000 that Metro PD had to spend just in our one center. That doesn't account for the people who they may have taken to an emergency room due to them having a medical issue and a psychiatric issue and had to wait with them. By fiscal year 20, we were able to decrease that wait time by 90%, so total hours to Metro PD of 135 with a yearly cost of $5,000. So pretty significant decrease there. Next slide. So all of that's great, but we still have some obstacles, and there's still some things that we are struggling with, but there's a lot of good work going on. The center that we operate is heavily staffed with nurses, mental health techs, master's level clinicians, and there's rising costs for that level of staffing. Nurses are a discipline that is a hot commodity, particularly in our city of Nashville, so there's always a rising cost in order to keep a stable nursing team. Then there's the growing percentage of people who we are admitting who are uninsured. And I think that's important to note. We treat anyone regardless of their insurance status. Majority of people we're treating, anywhere from 60 to 67% each month, are totally uninsured. The other big bucket of people, of coverage for people coming in, are folks with team care, and we do have contracts with the team care MCOs to pay for their care while they're with us. Commercial plans, those who are privately insured, or Medicare does not recognize the 23-hour observation care that we provide. So the only funding we get for those individuals is just for the time that they were with the psychiatric nurse practitioner or psychiatrist. So it's just a medication management rate. So as a result of that, in fiscal year 20, we are operating in a deficit of $900,000. Now, fortunately, we are a healthy non-for-profit who is able to weather that loss right now, but we can't continue to sustain that loss. And there are efforts from a statewide coalition to try to increase funding from the state. But we're all the time having to look for ways that we can keep operations going, but cut costs, because we can't continue to sustain that level of loss year over year. Next slide. And last but not least, some current and new initiatives that we're working on to improve the system is embedding crisis counselors in emergency rooms. We currently have a partnership with 2 of the TriStar or HCA facilities in town, Centennial Medical Center as well as Skyline Medical Center, where we actually have a crisis counselor in those emergency rooms who can assess individuals quickly and then get them placed into the best level of care. We want to really broaden our law enforcement partnership and fire and EMS partnerships. And so I think we've built a really good working relationship with Metro PD, and we want to continue to expand on that. We've been training officers for years, as Chief Huggins mentioned, and that has evolved over the last several years to be a lot more role-based training. And then we're really hoping to be able to do that with fire and EMS, because they are often the other first responders in a psychiatric crisis. Increased substance abuse services to combat the opioid crisis. We are in a partnership with Metro Health Department to have 2 clinicians who will respond to individuals who've had an overdose, who EMS has been the first contact with, but that individual needs follow-up services to try to get into treatment. And then last but not least, our facility is not currently Joint Commission accredited, but that is something we are pursuing in the next year and hope to receive that accreditation. And I think that may also help with some of the funding opportunities with commercial insurance plans as well as Medicare insurance plans. I think that is it.
Great. Thank you so much, Amanda and Damian and Angie, for your presentations. I'm going to open the floor to questions. We have a nice turnout with about 27 attendees on the video conference platform. So if you would, please raise your electronic hand You should be able to find that in your lower right screen. And I'm just checking the list to see if there's anybody here who's going to raise their hand.
I can't find it. I'm raising my hand.
Mr. Fisher, please go ahead with your question.
Yeah, well, I just like to, first of all, I'm so grateful for all of you for the work you're doing. God bless you. That's amazing. And I'm learning so much that I simply didn't know about what we are doing. What is the next step? Is this crisis treatment center, is it meeting the needs of the whole county? Do we need more? I suspect, I'm guessing, knowing from my own work, it's always more. But could you tell me what would be your dream next step?
Yeah, I guess I'll take that. My dream next step is if we could enhance our capacity. There are times when we have to halt bringing people in from emergency rooms in. We never stop people who walk in or police coming in, but people who are in emergency rooms who don't necessarily need inpatient care, there are times that we are just full and we can't bring them over. So increasing capacity is definitely on my wish list. Increasing our overall medical capabilities to take people who may have more serious medical issues, but again, don't meet inpatient medical criteria. And then third, and I think the thing that we'll probably have the quicker movement on in that regard is more co-response in the community with Metro PD. I think there's a lot of people who, 911 is called because they're presenting in a psychiatric crisis and they may be really agitated. And so police officers are the first ones to be dispatched. And I think if mental health was able to go along with them on the majority of those calls, we could significantly decrease incidences related to unnecessary arrests, as well as any uses of force. So that's my big three.
And well, mine, I'll kick in. You definitely the capacity at the crisis treatment center. I mean, when we were opening the doors, me and Amanda were talking that we were probably already forecasting a need greater than the size of the space that we had, and we actually hoped so. We hoped we would see that type of engagement with the community. So that's been a very a good positive. But also, there needs to be a transportation piece considered right now between the crisis treatment center and police, transporting people that may not be violent around the city into sometimes out of even this city into different areas, Chattanooga, other places, for beds is a very big time consumption for the officers that are not going to be on the streets that are doing that. So that's important, and definitely looking at how to expand on the partnerships that we have with mobile crisis. Like right now, we call them to the scene of barricaded subjects or where we have a mental health crisis event and have them inside our operations center consulting with our teams that are trying to de-escalate an event. So in expanding the use of those counselors that are outreach to be able to come out into the community and make them really mobile crisis, that is what we need in our city. I'm not saying they have to be with us on every call, but certainly it would be nice to have them accessible when we do call, more than at the crisis center, which we love. It's been great from 90 minutes to 8 minutes. What an opportunity we took with that, and to provide a 24/7 crisis treatment center in the 24th largest city in the United States was well needed, and it certainly has been a benefit to our community.
I'd also like to just check in with Angie Thompson to see if she would have any comments about what might be next steps.
Yes, I think one of the issues that is impacting our city is the overdose, and both the fatal and non-fatal overdoses and the response to that. This is something that's burdening multiple areas of the city. And I think we also need to think about the fact that when you're looking at children and you're looking at that they turn into adults, and those children have been impacted by adverse childhood experiences, that we need to really pay attention to that, pay attention to the fact that We know that adverse childhood experiences are fact, not fate. Therefore, those individuals who experience these, that there can be healing, that there can be building of resilience. And I think that we need to become overall a trauma-informed city. That is, that we really think about, what happened to you versus, why did you do that? So if we can lay that as an undergirding for our response in all areas of programming, whether that be with the schools, whether that be in the community centers, in the neighborhoods, with police, with medical components as well. I think all of those things are important next steps for our city to pay attention to.
Thank you, Angie. I noticed that Eli Foster has his hand raised. And Mr. Foster, would you like to ask your question or make a comment?
It took me about 10 minutes to find the hand raise button, but I found it, so we're in good shape. I have two questions. One is for the deputy chief. I noticed in your slide you mentioned having a person or an entity at the end that kind of oversees this, so as changes occur, that things are not lost. So my question would be, do you envision this under the police department? Do you envision this under the mayor's office? So what is your vision for this central hub? And then my second question, I guess, is directed more to Ms. Bracht, is a question of how, and this I just don't know, so it may be for all of you, how does the triage happen for a 911? So we were talking 911, then it goes to the officer, then the officer goes, and the officer calls for emergency, crisis support. So it seems like there's a lot of lost time in there. So has there been any experimenting with the triage happening in a different way that gets right to the service quicker as opposed to it going through 3 or 4 calls? Does that make sense? Sorry if I'm too confused in the way I asked that.
It does. I'll jump on both of those and let Amanda be the cleanup hitter on that.
Sounds good.
The first was why the centralized process. There always needs to be a process owner to have some sustainability and consistency and understanding of a program going forward. Because if I or you change our roles, if we were the only ones with the information, it goes with us. So when CMHSI started putting the health department over the behavioral health, which is in the charter in our county, was a great place. Plus the added advantage of an epidemiology department that can put together data from across programs that they can receive because they're the health department and put together aggregate data. See, I can't receive information about mental health information or medical health information, which both of those are addictive, which is medical, but I can share arrest information with government programs and collaborate data. So that central process owner is huge and important because we do not have shared data across metro government. The sheriff's department, we always get said, why do we arrest 2,000 people with mental health problems? I've looked into it. We diverted 98.5% of everybody we had information with mental health issues. But those flags in the sheriff's department and the medical side of things aren't visible to police. And those flags occur after evaluations occur and sometimes maybe 10 years old and not current with the events that happen are presenting. So that's why we need a central process owner that gathers this data and directs programming across government wide beyond mine and your tenure here. To sustain that. And secondly, when you go to the 911 evaluations of calls, simply, there's some experimentation happening across the U.S. on how to do that. We've always had a pretty good partnership. Like as soon as we get an event where we recognize it's a mental health, we're on the line with them going, do you know this person? Do you have any information? Can you come to the scene and help us? But they're not on duty on the police radio responding to every call. And even if that would take a lot of manpower, but in all honesty, it's in hindsight that we generally find out that somebody has a mental health issue because, again, the data is not shared. It is not readily available. And the calls don't go out as, hey, we have a person with a diagnosed mental health problem. It goes out with something's happening. And that's half the time all you get. Amanda, to you.
Yeah, no, Damian is exactly right. So all too often the call is, John Doe is agitated. He's yelling, screaming at his roommate. So that 911 dispatcher gets that. They dispatch law enforcement. But when law enforcement gets there, they may then see that flag or based on training go, okay, wait a minute. We're at a boarding home that's known to have individuals with mental health issues. This is a call to mobile crisis. And typically that officer is, on the phone with us very quickly in that situation. Or they pick up on things at the scene. They look at medication bottles and they call and say, wait a minute, there's a lot of medication bottles here. Some of them are even filled at the mental health co-op. So there is a delay, but it's usually because that information is not necessarily given at the point of the 911 call. Now, is that to say that there aren't some improvements that need to be made so that we can get that information quicker at the dispatch level? Yes, and I think that's some of the projects that Damian's talking about across the country. There are some cities where they have mental health actually stationed in 911 call centers so that they can pick up on that and dispatch a mental health person or a mental health team as opposed to law enforcement or in addition to law enforcement. So I think we definitely got some room that we can improve in that process, because when officers do know, then a pretty good response. But often they don't know.
Okay. Oh, well, I do want to say that there is one hand that has been up for a while, and that's Amanda Lucas, and then we will go to Sharon Roberson.
Thank you.
Yes. And so Amanda Lucas, would you share your question with us? And if you're not responding to a question, could you just mute your mics? Thank you so much. Amanda, did we lose you? Amanda Lucas, can you hear me? I think we might have lost the connection with Amanda Lucas. So I can see that her mic is open. Not sure what the technical difficulty is. But what we'll do is we will turn to Sharon Roberson. Sharon, would you open your mic?
Okay. I apologize if you covered this, but do you have the data on the people that you serve broken down by race?
We can likely get that data because we collect it. I don't have a report, but I can look at pulling that and get that to you.
The reason I'm asking that is there is a level of police discretion, because they're saying that they show up and they don't necessarily know if it's a mental health situation. They don't have all the data. So a lot of this is left up to the police officer. And that's when you can get into issues of bias. And I want to make sure that we are serving the community equally with what is an incredible resource.
Yes, and I will look at seeing how we can pull that data, because I know we have it. It's just pulling in a report form, and then we also pull it by sector across the city. So I can look each month about which sectors have a higher number of police initiated calls versus other sectors as well.
I'd like to also state that on the police arrests that do occur, when we have information about mental health, like it's in the call text, it's recognized by the officers, or we're taking some type of action where we go, hey, this is something that relates to mental health. The police department is at a over 98.5% diversion rate, meaning when we recognize that those people are not getting arrested, under 40 people in the several years that we have the information and looked at it. And when most of those individuals that were arrested were because it was not a discretionary issue. They were warrant arrests or FTBs, FTAs, domestic violence. Only a handful were ever discretionary. And when they are discretionary, Amanda Bracht calls me up and says, let's go over this and talk about what we can do better. So there's actually a good communication around these issues that pop up. What can we do to make sure our diversion is at its highest level? One is sharing the information and getting it timely, but the other part is reviewing the information that we do find and assessing how we can get better. And again, the mobile crisis, and Amanda specifically calls me up personally and says, hey, we got a couple I want to go over. So we're being very attentive to those issues and want to see how we can improve going forward.
And one thing, I just want to add real quick to that. One of the things we do see, and when we look at arrest data, to a point Damian made, is that a lot of people who are flagged with mental health issues and incarceration are being arrested for probation violations, misdemeanor probation violations. So we know that there's a lot of work we've got to do upstream on the prevention side of that.
Great points. And I just want to circle back with Amanda Lucas. and see if we can get her question. I can see your mic open, Amanda. You want to go ahead? Goodness, still no luck on that. I'm really sorry about any technical issues on this one. I did see that Larry Turnley had his hand up, and so I want to drop to Larry Turnley and see if Mr. Turnley would like to open up his mic.
Yes. I got on the call late, and I wanted to know, do this facility have like isolation rooms, or do they use any type of restraints on the patients? And while the patient's there, can the patients be charged with a crime if they unruly? Anything like that?
Good question. So we have two in our high acuity area, two safe rooms. These are padded safe rooms that are hospital, kind of, for lack of a better term, hospital grade safe rooms if somebody is actively trying to hurt themselves or others. Our goal is to get them out of that room as quickly as possible, as long as they're not trying to hurt themselves. We do not do hand restraints or any sort of physical restraint in that way. It's basically to get them in the safe room, let them calm down, initiate medication to help calm down if need be, and then get them out of that room as quickly as possible. We average less than 5 uses of those restraint rooms in a month of the people who were brought in. And that's something we track every single time there's a use of the safe room. We look at the video of what led up to that situation. We also have non-secure quiet rooms, as we call them, that are just if somebody is not doing well in the open unit area and they are not hurting themselves or anyone else, but they're clearly having a difficult time being around others, then we may move them into a single room where they can have a little bit of quiet time and counselors meet with them.
And are they monitored by doctor, police, or the sheriff department? Who would be monitoring them?
That's mental health staff. These are staff from the mental health cooperative. So they're it could be a mental health technician, which are folks who we train in verbal de-escalation, and if they need to, they can do a physical hold to get somebody in a safe room. But their goal is to monitor individuals and to be on the units at all times. And then we have nurses, we have master's level mental health counselors. We also have a peer specialist, which is someone with lived experience of mental health issues or addiction that has now been stable, and they counsel their peers and are able to engage them in often a much less intimidating manner than the professionals. But it is not police officers, it is not sheriff's office staff. These are all mental health professionals as part of our mental health team that are on our unit. In fact, we try our best when officers bring somebody in for them not to leave what we call the police airlock area, which is literally the side door where police bring them in. They hand off to mental health staff, and then we thank the officer and they move on.
Great. Well, it is now 12:58, and I would like to thank all of our panelists for their time today. And I want to thank all the members of the commission who made time for today's presentation. This presentation has been recorded and will be posted to Metro Nashville's YouTube site, which means that it will be publicly available. We will be sure that the full commission gets a copy of this. And certainly if there are more questions, we can follow up with Ms. Bracht, Deputy Chief Huggins, or Ms. Thompson. Thank you all for joining us today.